Hello everybody. Today we are going to discuss about sedation in the ICU. So propofol is the lipid soluble alkyl phenol derivative that binds to the GABA receptor, causing sedation and amnesia. It is most used induction drug in the anesthesia given its rapid onset and the reproducible pharmacokinetic properties. Additional useful feature are the reduction of the airway resistance and its neuroinhibitory effects. Negative properties arise from the suppression of the sympathetic activity and its associated myocardial depression and peripheral vasodilation, potentially leading to the poor clinical outcome. Of importance, higher doses of the propofol on induction are associated with the more profound decrease of both systolic and diastolic blood pressure and with higher frequency of apnea, especially in the older patient. This effect may have major impact on the critically ill patient presenting with a different degree of cardiac function impairment and hypovolemia. Now about midazolam. Midazolam is the short-acting benzodiazepine with the sedative and the amnestic property resulting from the GABA receptor complex agonism. Like all benzodiazepine, midazolam has not analgesic properties and its anti-seizure effect makes it an option for the induction of patient with the status epilepticus. At the routine induction dose of 0.2 mg per kg, it has been associated with the reduction of mean arterial pressure in healthy patients up to 25%. This hemodynamic effect may become more pronounced and clinically relevant in critically ill patients with hypovolemia and shock and with dose-response relationship. The reduction of the induction dose in attempt to limit hemodynamic impact of midazolam can be associated with clinically relevant delay of onset of intubation condition and of deep of the sedation achieved. Furthermore, sedation with the benzodiazepine increases the risk of delirium. Given all these limitations, midazolam is rarely used as the single induction drug, while it is more frequently added in small doses that is 1 to 2 mg in normal weight adult patient to the main induction drug that is ketamine to benefit from its amnestic properties. Now about etomidate. Etomidate bind to the GABA type A receptor, specifically at beta subunit in the CNS, thereby increasing the affinity of the receptor for the GABA. This enhances affinity leading to the hyperpolarization of the neuron, which reduces the excitability of the neuron and induces the hypnosis. Due to its rapid onset and the minimal effect on cardiovascular stability, etomidate is frequently used as an induction agent for tracheal intubation in critically ill patients, although its availability is limited in some countries. The major concern of the etomidate is the development of adrenal insufficiency. Etomidate suppresses the production of cortisol through the inhibiting 11 beta hydroxylase, which is a key enzyme for cortisol and the aldosterone synthesis. Adrenal suppression typically lasts from several hours to the days. Given that etomidate is preferably administered in the hemodynamically unstable patient, adrenal suppression may further complicate the circulatory management. About ketamine, among various hypnotic agents, ketamine has a unique mechanism of action that involves glutamate, an excitatory neurotransmitter. By acting as a competitive antagonist of N-methyl D-aspartate receptor, ketamine blocks the excitatory neurotransmission pathway triggered by glutamate and induces dissociative anesthesia. Induction with the ketamine carries the several beneficial properties for the tracheal intubation in critically care setting. For example, by inhibiting presynaptic catecholamine reuptake and increasing norepinephrine level at postsynaptic receptor, ketamine stimulates the sympathetic nervous system, leading to the increase in heart rate, blood pressure, and cardiac output. All these effects can contribute to preventing peri-intubation cardiovascular collapse, especially in hemodynamically unstable patients. It remains uncertain if ketamine is better than etomidate in terms of restoring hemodynamic stability. Unlike other hypnotic agents, ketamine has a minor effect on the respiratory function. As such, maintained spontaneous breathing and the preserved airway reflex are also key features, which are helpful in patients with the severe hypoxemia or at high risk of aspiration. In addition, ketamine has a bronchodilation effect, which is protective for obstructive lung disease like acute asthma. Adverse effects of ketamine are hallucinations, nightmare, and hypersalivation. Unfortunately, assessment of these symptoms have been rarely conducted in the critically ill setting, and their clinical significance remains uncertain. Ketamine was traditionally concerned for increasing intracranial pressure. However, recent literature suggests that intracranial pressure is not affected or even reduced with the ketamine administration in patients with acute brain injury. Therefore, there is no convincing evidence to support association between ketamine use and increased intracranial pressure, while avoiding peri-intubation hypotension is of pivotal importance to maintain adequate cerebral perfusion pressure in this circumstance. In addition to the above mentioned pharmacological characteristic, ketamine is inexpensive and is easily available, making it a useful induction agent also in the resource limited setting. Next induction agent is thiopental. Barbiturate are no longer readily available, and given number of potential detrimental effects are rarely used in the setting of induction of critically ill patients. Thiopental is one of the ultra-short acting barbiturate that act on the barbiturate component of the GABA receptor complex to induce the sedation. It exerts the venous dilatation and negative inotropic effect, resulting in hypotension in doses used for the induction. Furthermore, thiopental lead to the histamine release, inducing bronchospasm, therefore should be avoided in patients with the reactive airway disease. Both in vitro and in vivo evidence reported suppression of blood cell recruitment, activation and activity triggered by thiopental, raising concern on its use in the septic patient. To summarize, there is no indication for the use of thiopental in places of other more commonly used agents. Combination of induction drug. In addition to the induction agent described above, some other drugs may be used in combination during induction of critically ill patients. Fentanyl may be co-administered with the hypnotic agent with the aim to blunt sympathetic response triggered by pain associated with airway instrumentation or with underlying disease. Randomized trial compared fentanyl with placebo in addition to ketamine and rocuronium among patients undergoing emergency intubation. Fentanyl increased the risk of hypotension but did not affect other relevant outcomes, including first pass success rate or mortality, which support its avoidance to maintain hemodynamic stability. An admixture of ketamine and the propofol, that is ketofol, may offer hemodynamic instability driven by propofol through sympathetic stimulation of ketamine. A randomized trial comparing ketofol with the etomidate in 163 patients undergoing emergent intubation found no difference in the post-induction hemodynamic condition, suggesting its favorable hemodynamic profile. However, admixture ratio is neither well-defined, standardized, and not approved. Now, emerging clinical evidence in the guideline recommendation. During last year, evidence on the hypnotic drug sedation and clinical outcome has accumulated, mainly focusing on two induction drugs, that is ketamine and etomidate, having the most favorable hemodynamic profile for critically ill. From analyzed evidence, the SCCM guideline did not detect any meaningful difference of etomidate compared to ketamine, so that given its availability, experience with its use, and low cost, etomidate is considered reasonable option for rapid sequence indication in critical care. Now, etomidate versus ketamine. Concerning the hemodynamic effect in RCT by the Matchett et al., ketamine increases the rate of post-induction cardiovascular collapse and the need of rescue vasopressin, while no difference in the post-induction mean arterial pressure or drop of systolic blood pressure after induction was observed between ketamine and etomidate group. Taken as a whole, etomidate may carry a non-negligible mortality risk without definitive hemodynamic benefit compared with the ketamine. Available data then support the use of ketamine over etomidate, since the difference in hemodynamic profile, if present, uh, seems to be of not clinical relevance and could be balanced by preemptive and rescue vasopressor, while etomidate seems to expose patient to high mortality risk. Now about propofol versus etomidate. Propofol is widely used as an induction agent in the operating room, but has no concerning effect on hemodynamic, which prompts evaluation in the critically ill patient. Several guidelines pointed out the higher risk of cardiovascular collapse driven by propofol, while SCCM guideline suggested no difference between propofol and etomidate in terms of mortality, frequency of hypotension, or vasopressor use during peri-intubation period. A secondary analysis of intubate study investigate variables associated with post-intubation cardiovascular instability. After applying inverse probability of the treatment, weighing method to balance population of for covarieties, covariates potential associated with the post-intubation cardiovascular instability, propofol was identified as unique modifiable intervention associated with higher frequency of post-intubation cardiovascular instability, irrespective of baseline blood pressure. So propofol was used in 41.4% worldwide, either as a single hypnotic agent or in combination with other molecules like ketamine and etomine. The median overall dose of propofol was 1.12 mg per kg. Interestingly, propofol was significantly more commonly used by anesthesiologists who administered it in 49% of patients compared with non-anesthesiologists who administered it in 32% of patients. Of note, the association of propofol with the worst hemodynamic outcome was detected also when added in mix of other induction molecules. Although complex drug-to-drug interaction may be of importance, the profound influence of propofol on hemodynamic status, especially at high administration rate used during rapid sequence induction, may play an important role. Also at low doses, typically used in co-induction with other molecules. Despite the observational nature of this finding cannot exclude the role of confounder, adverse association are pharmacologically plausible, justifying the avoidance of propofol to reduce the risk of hemodynamic collapse in favor of drugs with the better safety profile in critical care such as ketamine. Now, the current knowledge gaps and the future research priorities are knowledge gaps, optimal type of induction agent to avoid cardiovascular instability. A large-scale multicenter randomized control trial comparing ketamine and etomidate to evaluate their effect on peri-intubation cardiovascular instability and long-term patient outcome. Then optimal dosage of induction agent. Dose response relationship of each induction agent in terms of hemodynamic stability. Development of clinical prediction model to considering induction dose and the clinic and patient clinical status. Preemptive use of vasopressor to mitigate post-induction collapse. An international multicenter randomized control trial on preemptive infusion of noradrenaline is ongoing. So, effective and safety of remimazole as an induction agent in critically ill patient. Perspective study comparing remimazole with ketamine and etomidate to assess the applicability of remimazole in critically ill setting. Thank you, guys.